Hello again, and welcome to today's webinar on creating an effective MRI patient safety screening process. My name is Colin Robertson. I'm Senior VP with Metrosense, and it's a pleasure to be able to host this webinar with Tobias Gilk. For those of you less familiar with Metrosense, we're the leading provider of advanced magnetic detection technologies. Our FerroGuard ferromagnetic detection systems are protecting patients and staff now in 36 countries around the world. Before handing over to Toby, and especially for those of you for whom this is your first Metrosense webinar, I have a few housekeeping items to cover to make sure we all get the most out of our time today. Firstly, today's session will be available on demand after we finish. Just follow the same link as you used just now, and an email will send you after the session. Of course, please feel free to share this with any of your colleagues who are unable to attend today. I'll now quickly take you through the various parts of the screen in front of you. Starting on the left side is the Q&A window. I'm sure there'll be lots of questions for Toby today, so please enter yours as early as you can. The window in the center of the screen is where you'll see the slides throughout the webinar. If you'd like to change the sizes of any of the windows, just use the controls at the top right corner of each window. To hide or redisplay any of the individual windows on your screen, just use the buttons at the base of the screen. At top right, we're pleased to provide you a number of links to MRI safety resources. You'll find here a link to the Metrosense MRI Safety Resource Center, where you can also access on-demand versions of all of our webinars, our new MRI Safety Talks podcast series, and other MRI safety content. Now, I know that many of you will be looking to obtain continuing education credit for attending this webinar. The yellow button highlighted here will enable you to download your certificate. You need to have watched the webinar, though, for a minimum of 45 minutes before doing so. You can download and print at the end of the webinar, and there will also be a link in the email you'll receive a couple of hours after we close. The final window, lower right, gives you a brief biography of Tobias Gilk, our speaker. He will be introducing himself in just a few seconds, but let me say here how proud we are to have Toby with us again today. Lots to cover in today's session, so let me now hand over to Toby.
Thank you very much, Colin, and welcome to all of you to our presentation, Putting an End to MRI Cancellations and Delays Through Effective Patient Safety Screening. As Colin said, my name is Tobias Gilk. A little bit about me. I am an architect with RAD Planning, Radiology Planning. I'm one of the board members of the American Board of Magnetic Resonance Safety. I'm a member of the ACR's MRI Safety Committee, founder of Gilk Radiology Consultants, and a consultant to Metrosense. And my disclosures, I'm an employee of RAD Planning. I do ongoing consulting with Metrosense. And given my role with the board of the ABMRS, I also like to include this little disclaimer that none of the information I'm going to share with you today is information that appears on any of the ABMRS examinations. Now, with the housekeeping out of the way, what are we going to talk about for the remainder of our hour? We're going to talk about the value of screening and the way in which that provides useful information for informed decision-making. We're going to break screening down into the constituent parts, clinical and physical screening. We're going to talk about steps you can take to improve information gathering, all of which has the goal of helping you to reduce delays and cancellations for MR safety-related questions. To do that, let's try and identify what the value of collecting better information is. In part, the value proposition is going to be driven by the type of provider. So for private providers that are either paid directly by the patients or through insurance third party, the more we can effectively reduce delays or cancellations, that means the more studies we get done in a day, a week, a month, a year, And the more studies we get done, if we're paid on a per study basis, that equates to greater revenue for the provider. Now, I don't have numbers for every country, but I'm very familiar with sort of the economic model in the United States, so let's use their numbers. In the U.S., the average MR exam is about 40 minutes or 2/3 of an hour in duration. And on average, the provider winds up getting paid $650 to perform that study. So if we reverse engineer the value of 1 hour of magnet time, we identify that it's close to $1,000 an hour, or a little bit more than $16 a minute. That is the value of time in terms of productivity, what you get, what a provider gets for being able to fill that time with patient studies. Or said in a slightly different way, every minute of delay that is otherwise avoidable, every minute of delay costs a facility a little bit more than $16. So the amount of time from the last slide till now is $16 worth of revenue. For every last-minute patient cancellation or an indefinite postponement, an empty time slot, well, that's going to cost the provider $650 in revenue. So you can see that these incremental little delays, or a patient here, a patient there, you begin to multiply that, a couple patients a day times 6 or 7 days a week in terms of service over 52 weeks in a year. And we can be talking a pretty substantial piece of revenue that just gets lost because of questions about screening. Now, from those of you on the public provider side of things, please don't think that I'm forgetting about you. Public providers have the exact same concerns and considerations. The metric that they use to measure it, however, is different. So we're after the same thing. We are after a fewer number of delays or cancellations. We are after a greater number of studies. The metric by which we measure that success or failure is how long does it take for a patient to wait to get in to get their MRI at our public facility. We can and should use the same techniques to reduce patient delays and patient cancellations on the public side, not to pump up revenue, but to do a better job of serving our beneficiary population, reducing wait times, improving the efficiency, the capacity of the 1 MRI or 2 or 12 MRIs that your hospital or system control, and using those assets to the greatest possible benefit. So I framed some of the value for private providers. I framed the value for public providers. Let's not forget the patient. The more effective and efficient we are, the greater number of patients can get timely exams, appropriate exams, and get better diagnoses. And if we manage to do this in terms of better information collecting and better screening process, ultimately it makes the MR studies that the patients receive safer. So we can improve revenue, we can improve throughput and efficiency and beneficiary population service, and we can improve safety and quality of care delivered to the patients. If we do these things, it is a win-win-win all the way around. Said plainly, the better we are at collecting information and effectively clearing MR patients, there are benefits for everyone. Now, I'm focused primarily on patient screening, but when it comes to screening, an effective and appropriate process is not limited only to screening patients. We need to screen other people who come into the controlled access part of the MR environment. So this means, obviously, patients, but any visitors, anybody who might be accompanying a patient, The physicians, including the radiologists, nurses, respiratory, anesthesia, engineering, maintenance, cleaning staff, anybody who comes into the controlled access part of the MR suite, we want to make sure that we're not jeopardizing their health and safety or the health and safety of anybody else in the suite. So screening really needs to be universal. It needs to apply to every individual entering controlled access parts of the MR suite. Full stop, no exceptions. So when I say screening, what does that entail? There really are two constituent parts to screening for MRI safety. We need to screen people for clinical contraindications, and we need to screen them for physical contraindications. And we'll take a look at each of those two. So clinical contraindications, what we're really interested in are implants and devices, things that may be adversely affected. Clinical conditions of the patient. For example, maybe they have incredibly low renal function and they would be at risk if we were to use certain types of gadolinium-based contrast or certain quantities of gadolinium-based contrast. So we want to identify these clinical contraindications. We want to know these long before the patient even shows up at our doorstep. What are some of the things that might be constituent parts of the clinical screening? Well, this data is from the Pennsylvania Patient Safety Authority, and the link URL is at the bottom. And this data is just for things that made it into the magnet room. Now, there's a whole separate category of things that we should identify before they make it into the MRI scanner room. But here we have ECG and pulse ox leads. We have medication pumps. We have patient monitoring equipment, all clinical support infrastructure, equipment, material that made it into the room with the patient. And again, this data that we're looking at right here doesn't even track contraindicated implants or devices or renal impairment and risk factors associated with contrast use. But just of the things that make it into the magnet room, 45% of them are related to clinical patient safety. Which brings us to the second part of an effective screening protocol. After we screen them for clinical contraindications, we want to make sure we identify any physical contraindications. And these are primarily what patients are wearing or carrying. This can be clothing items. This can be stuff in their pocket. This can be shoes that look like athletic trainers but are the concealed roller skate shoes that the kid is wearing. So we want to identify objects, material being worn or carried by the patient, by the subject, by anyone entering the controlled access area. We want to identify potential torque or translation risks associated with magnetic attraction. We want to identify any potential heating risks of material objects that are brought with the patient into the MRI room. And here again, we return to the Pennsylvania data. And again, this data only reflects items or material that made it into the MRI scanner room. And just over half, or 55% of this, relates to clothing items that were improperly or ineffectively screened. Mobiles, scissors, canes, walkers, knives, lighters. All of these are items that should be identified, caught during the physical screening of the patient, which should involve changing or disrobing the patient out of their street clothes and changing them into clothing, scrubs, gowns provided by the facility. And in addition to that, the use of ferromagnetic detection for screening of patients or objects material. Ferromagnetic detection has value not only in the worn or carried material, our sort of physical screening, but there is an increasing body of evidence, published literature, that talks about the ability to identify some implants and devices, or identify the presence of some implants and devices. So the ferromagnetic detection systems do double duty in terms of reinforcing both the clinical screening piece and the physical screening piece for everyone entering the MR controlled access area. So we have two constituent parts of screening, clinical screening and physical screening. So we should use the exact same process for everyone, right? In a word, no. We should not use the same process. We need to adapt the process based on the patient's ability to participate or staff ability to participate, where they're coming in. Do we have changing facilities? Do we have ferromagnetic detection for screening? Where do we have these resources? If you break down different workflows and patient paths, staff paths, you'll figure out that it would be a practical impossibility in a lot of sites to do the exact same thing for everybody who needs screening. So we need to tailor a screening protocol based on the resources available to us for each of these different types of people. So let's take the easiest, most prototypical version of different groups, outpatients. Where, for your MR facility, where does an outpatient screening process begin? Does it begin with the referring physician at the time of referral? Does it start with the schedulers when they're calling the patient to make the appointment? Or does it start does your screening process really only begin after the patient has arrived at the site on the day of their study? Click the button that best corresponds, then hit the submit button on the right. I'll give you 5, 4, 3, 2, 1. Excellent. Click and submit, and moving on. So as we're getting into talking about the actual mechanics of the process, it's probably fair to give attribution and let you know where I get these ideas from. I have no pride. I will beg, borrow, and steal a good idea from anybody I see it from. And these are a few of the institutions that I have had the privilege of either working with directly or interacting with folks who have helped me better understand effective ways to conduct the screening process. Ideas that you're about to hear me present are probably borrowed or adapted from the institutions you see on the screen, and probably a number of others that you might recognize as well. And I would encourage you to do the exact same thing. Any ideas in this presentation that you see that you think would be beneficial at your site, please, please, please steal them from me and put them to use in your facility. Traditionally, MRI patient screening really began and ended on the day of the exam. We didn't know what we were going to get until they showed up. I would challenge you that just because that's the way it has been done doesn't mean it's the way it should be done. It certainly doesn't mean it's the best way. I would encourage you to look at ways that you can engage your referring physicians, not to fill out the entire screening form, but to identify a handful of red flag questions, hard contraindications, things like aneurysm clip, neurostimulation device, cardiac device like a pacemaker or an ICD. Have your schedulers train them, build their competency so they can verify the red flag stuff, but also ask what I'm calling orange flag contraindications, things like a lumbar stimulator or spinal rods, and have them identify on the day of yellow flag, adapt on the fly kind of contraindications. And this might be an MR conditional medication pump that we need to meet specific conditions of. The earlier you start the process and the more time you give yourself to resolve complications, the better off you'll be. And the earliest that's possible is the referring physician having the conversation with the patient oh, I think for your condition, maybe it would be a good idea to get an MRI to take a look at your shoulder. And use that interaction between the referring physician and the patient to begin to collect information that is necessary for clearing that patient. So what might that look like? What if the referring physician just asked 3 or 4 questions, asked about whether the patient had a stroke or an aneurysm clip, or they had cardiac pacing device, or they had medication pumps. And if they didn't have any of those, well, yes, it's okay to proceed, and we know exactly how to go forward with that. But what if they say, the question is it safe to proceed? The question is no, or I don't know. What if the patient has a pacemaker, right? Well, if you can identify those questions and resolve the question, oh, it's an MR conditional pacemaker, not a problem. We do MR conditional pacemakers on Thursdays when we have the cardiology staff in the department. Well, now you have all the information you need to be able to proceed, and so you resolve that question and the patient moves on towards scheduling. Or you identify early on, before the patient even shows up at your doorstep, that you have an unresolvable situation, and so the patient doesn't advance towards scheduling unless and until we can get the information we need to resolve the question. So now at the scheduling call, not only does the scheduler, have the ability to say, oh, Mr. Thompson, we have you scheduled for next week, Thursday. The scheduler has the opportunity to essentially identify that the initial referring physician questions have been resolved. If there are things that require coordination with the clinical staff, the scheduler can identify and collect that information. And at the scheduling call as well, we may be able to identify, no, we're not sure that that's okay. How do we resolve this question? Maybe it's an MR conditional implant or device or a piece of shrapnel, whatever it is. We might have a second resolution step to try and figure out, do we have the information? Can we get the information? Do we know that it's safe to proceed, or at least that the variables are ones that can be effectively addressed on the day of the appointment? If it involves some kind of long literature search or looking up MR conditional information from an implant vendor or some third-party resource, knowing what is involved in that and whether that information can be collected on the day of the study is really important. Otherwise, we're setting ourselves up for failure by sending patients for whom there are unresolvable questions. So resolve them or collect the information that allows them to be resolved at the time of scheduling. Which brings us to the day of appointment. And again, the goal here is that we want the patient to show up and the caregivers to have all of the information necessary to make an informed assessment about that patient. Ideally, that informed assessment is, yes, the patient's ready for their study, let's go ahead. Or maybe it might be, oh, this is the patient who has the MR conditional implant and we need a special pulse sequence to get the SAR down below 1 watt per kilogram or whatever it is. Not a problem. We can modify the sequence. We can get it there. But whatever is left on the day of the study ideally should be either, a no-brainer immediate resolution, or this is something entirely within the technologist or radiographer's control to make whatever modifications need to be made to allow the study to go forward. And the objective is that we should have effectively no delays or denials of study on the day of, at least not for safety reasons, if we follow these steps prior. In terms of data collection and data sharing and reviewing with the radiographers, the technologists, the radiologists to make sure that these questions are fully resolved or resolvable on the day of the study, then proceeding with the exam should be quite simple, straightforward, and direct. we don't often think of the referring physician having a direct role in MR safety and MR patient screening, but this was a lack of imagination on our parts. The referring physician is the person who probably has the greatest access to the patient's medical record, medical history, certainly more so than the radiologist or technologist on the day of the study. So leverage the referring physician and their closer knowledge of the patient's medical history, medical record, to identify potential concerns or conflicts, and leveraging that existing body of knowledge. And again, we're not interested in having the referring physician fill out an entire screening form, but having them understand that they have a role to play in the clearance of this patient and getting them to facilitate that clearance. That will make everybody's lives a lot smoother and easier. And here we have the results of our first poll question regarding when your screening process begins. And okay, all right, more or less what I expected. Clearly, we have room for improvement here. If anybody wants to delve into these more deeply, we can talk about it during the Q&A session at the end. Yeah, okay, let's move on. So the goal of screening. Better, more timely information allows for better decision-making. The goal should ultimately be to try and get as many patients to, yes, we can scan you at your scheduled time safely and effectively. Now, to do this, we need to collect the critical information as early as possible. This is not collecting information for the sake of collecting information. This is not busy work. This is very tactical in terms of asking the questions that are appropriate to that step in the process. To do this, let's test this a little bit. Let's go through some of the scenarios and let's identify the ways in which information about a patient, about an implanted device, a foreign body, information about the specific study, how it shapes the patient approval process, patient clearance process. Let's start with probably the most prototypical, typical patient cohort, and that's ambulatory patients coming in. Generally speaking, they're going to tend to be lower acuity, lower priority studies. Because they're not urgent or emergent, we're not rushed, so in theory at least, we have better access to a patient history. So let's just take an example of a patient that perhaps may walk in the door to one of your MR facilities. So here's a situation. We have a patient who has a ball bearing, a BB, a pellet in their arm, near their elbow, just below the elbow. Shrapnel, foreign body. We have no idea what its composition is, other than the fact that it shows up, high contrast on an X-ray study, so we know it's dense. So the patient walks in for an MR. Well, let's put it to you. How would you feel about a patient walking in with a BB in their arm? How would you feel about proceeding to an MR with this condition? And so here I'm going to put you on the spot. So you have this patient, 3 millimeter diameter ball bearing BB just below the elbow. Would you consider scanning this patient? Yes. No question, no problem. We will scan this patient, doesn't matter what. Maybe option two, I'd want to gather some consensus opinion. I'd want to talk it over with my colleagues, other technologists, other radiologists. I'm not saying no, I'm not saying yes. Or the third option, no, this is an unidentified, unlabeled foreign body inside the patient. No, I would not consider scanning this patient because it's a foreign body. Click the radio button that most closely corresponds with your answer. Make sure you hit the submit button. And 3, 2, 1, moving on. So taking our BB example, let's actually run through a quick assessment. So collecting the information about the patient, about the subject, is the first piece of this. The second piece of it is putting that information into use. So we're going to do what is frequently referred to as a 3 buckets analysis, or canal method analysis, where we look at the 3 electromagnetic fields: static field, time-varying gradient magnetic fields, and the RF magnetic fields. And we're going to look at the potential risks or potential harms to the patient that arise from each of those 3. And then the last category, device function, relates to implants and devices. So first, with static field. What happens to an object in the presence of a static magnetic field? It is either drawn to the magnet or twists to align with the magnet. And those forces, the translational or attraction force or rotational forces, can cause damage to human tissues if if the object is embedded inside the patient. Because the object is small, of very low mass, the amount of force that it is capable of producing in a magnetic field is actually limited. 3 millimeter ball bearing, if you haven't done so before, put it in a little pill bottle or something that will allow you to be sure to keep it contained and walk up to the mouth of the bore of the magnet. You begin to get a sense of what the magnitude of forces involved in this. Now, because it appeared spherical without any deformation on the film that we've looked at, it would be great to have 2 views to verify that, but with the single view, it's a small mass. It's not going to experience significant torque because it is fundamentally spherical in shape, and it's not going to experience a whole lot of translational force because it's small and a low mass. So it just can't produce that much force in general. So from a static field standpoint, quite honestly, for the BB, I'm not worried about it. Time-varying gradients. Time-varying gradients produce neuromuscular stimulation, or if the object is really big, which a BB isn't, it can produce vibration, but that's out. This is so tiny that the time-varying gradient that hits the ball bearing is essentially going to be the exact same energy that hits the surrounding tissue. So there's really no delta. There's no increase in risk associated with time-varying gradients. So I don't see that as being a risk either. RF magnetic fields. The FDA, US FDA, has come out with some draft guidance. I don't think it's formal yet, formally approved, but they essentially said, hey, implant and device testers, if the object is less than 2.5 centimeters, 25 millimeters in size in any direction, then for 3T and below, we don't consider there to be an appreciable heating risk at all. You don't even need to bother to test it. So 3 millimeters being substantially smaller than the 25 millimeter conservative cutoff point by the US FDA tells me that the heating potential for the RF magnetic field really is non-existent as well, which leaves only device function, but there is no function to the BB. It doesn't do anything inside the patient, so we can cross that one out. So our 3 buckets plus function, 3 buckets of static field, time-varying gradients, and RF, in each of those 3, in my opinion, the risk is very low. Now, if the BB was deformed and it, had sharp edges or something, different set of conditions, but just based on a spherical intact BB inside the muscle in the forearm, in my opinion, the risks associated with that are very, very low. And I would probably be in the go ahead and scan them camp if we were asking me about that. So now that I told you how I would answer, let's look at how you answered this before. Okay, all right. Again, this is actually kind of what I would expect from this. Thank you, everyone, who gave us your answers. Let's do another example, but this time let's take an inpatient. Now, inpatients as a cohort tend to be a little bit more complicated in terms of screening, in part because if they're inpatients, there's something wrong with them, so we can presume a greater frequency of comorbidities. They also have lower mobility themselves, which can, depending on the study, depending on the patient, make patient preparation or the physical screening piece of it a little bit more difficult to achieve. So let's take an inpatient. Let's take a patient from the ICU who may be, semi-conscious, not awake and alert and responsive. And in this patient, there is a fractured pacer lead. The patient had a pacer at one point in time, and when they were trying to remove the lead set, the lead broke, and there's just a remnant of a lead left in this patient. And the question I would put to you is, would you consider scanning this patient, patient with a broken, abandoned pacemaker lead? I'll constrain the scenario just a little bit to hopefully make it easier to for you to give a definitive answer. So the patient, we're scanning the patient's knee, and this patient has this abandoned pacer lead. And so I'll ask you the exact same question that I asked you with the BB. Would you consider scanning this patient, a knee study patient with a fractured abandoned pacer lead? Would you consider scanning their knee? Number one, yes, without hesitation. Maybe I'd want to gather a consensus opinion amongst my colleagues, or no, this would be quite dangerous. I wouldn't consider doing this. So knee study of a patient with a fractured abandoned pacer lead. Pick the bubble on the left that most closely corresponds with the answer you would give. Hit the submit button, and we will move on in 3, 2, 1. Thank you. So now that I've gotten you to lock in your answer, let me run you through the formal structured risk assessment. I strongly recommend every site has some version of this. It reduces variability, improves consistency in terms of clearing your patients. So I'm going to run through this very quickly. Static field for torque and translation. I'm not aware of any permanent pacer leads that have significant ferromagnetic content. So in general, I'm inclined to just disregard static field. Which part of the body we're doing a study of doesn't really influence static field very much because you're going to be in the magnetic field. But in this case, because of the nature of pacer leads, I'm not terribly concerned about that. Both time-varying gradients and RF fields, because they're insulated leads, they allow for the electromagnetic energy to enter the lead and then conduct along the length of the lead and deposit in a focused, concentrated form at the terminus of the lead. Time-varying gradients tend to be at their maximum at about half the diameter of your bore, up or down, away from image center, isocenter. So if you have a 70 centimeter bore, about 30 centimeters, 35 centimeters superior or inferior to where you're imaging is where gradient amplitude will be maximum. I'm 6'4", which is what, 185, 190 centimeters. If we're imaging my knee, the gradient amplitude incident on the upper chest where this abandoned lead is going to be very, very, very small, and in my opinion, not a safety concern. So the habitus or height of your patient will come into play on this. RF magnetic field. If we're imaging the knee, presumably we're using a transmit-receive knee coil, which means the radio frequency energy is being constrained to just that anatomy. We're not irradiating the entire patient, and certainly not the upper chest. Now, yes, it is true that the heating risk in electrically conductive materials is at least in part the E field, the electrical field component of radio frequency energy, and that does travel through the body. But depositing RF in the knee, you are not going to get meaningful, risky amounts of E field traveling all the way up to the upper chest. So that's really not an issue. So that just really leaves device function left. And we can effectively cross out device function because while it did serve a purpose when it was attached to a pacemaker, now that it's just sort of floating loose in there, there really is no device, no function to preserve. So we can cross that out and ignore that. And as before, now that I've given you my opinion, now let's circle back and see what your thoughts were about performing the knee study on the patient with the broken, abandoned pacer lead. Okay, all right. A little bit surprised, but not much. Okay, I'm not going to ask you to do this on each one of the scenarios, but I did want to kind of get a quick snapshot, a sense of where the group generally was. Thank you again for submitting your answers. Also, you may want to start thinking about submitting Q&A questions for the end of the session. Just planting that thought for you. So our third example, and we're not going to do a specific case on this, is the idea of the unreliable historian. We don't really need to do a specific case because this is more about your process, your procedure. If you have somebody who, because of a language barrier or altered state of consciousness, or they're young, or whatever the reason may be, that you don't feel confident that you're getting a full and accurate clinical history, how do you go about clearing that patient? Do you simply take them at their word even if you have doubts? Do you say, well, I gave it the old college try, but that information just doesn't exist, so we're going to presume as if everything is fine? How do you proceed when this happens? Sites that I'm aware of, some of them, if a patient is designated as an unreliable historian, they will proceed with films, head, chest, abdomen, pelvis, plain x-ray, to try and identify if there's anything in those regions about which they have concerns proceeding with an MR study. Or they may do some sort of physical exam to try and identify if there's evidence of prior surgical intervention or traumatic injuries, or maybe some combination of films and physical exam. So we won't do it as a poll question, but I'll just sort of put the question to you to mull over. How do you handle patients with language barriers, altered consciousness, patients who you have reason to suspect are not being fully forthcoming about their clinical history? What is your process? How do you go about trying to identify questions or concerns to be able to resolve? Or do you not try and identify them? The last example, and I will do sort of clinical examples for this, I'm tagging this as allied clinical staff, but this, again, could really apply to patients as well or visitors. But allied clinical staff, a lot of facilities that I have seen and tried to get to change consider a white coat as an all-access pass, that a doctor can essentially go anywhere in the hospital that he or she wants to. So consider whether your MRI department has sort of a staff entrance or an inpatient entrance, a back door, if you will, that allows people to come into the controlled access parts of the MR suite without having gone through the physical spaces that are your operational cues to perform the clinical screening and the physical screening. Can somebody essentially, by virtue of the fact that they came in a side door or a back door, can they circumvent the screening process? And if so, how do you actually conduct screening? How do you make sure that that individual walking in isn't a risk to themselves or others? And I'll use the example of an on-planted insulin pump. So the picture on the right is Nick Jonas, an American pop star singer, And you may not be able to see that thing under his shirt. Let me zoom in on that picture here. This is an on-planted insulin pump. And the reason I want to bring this to your attention is that some medication pumps, including insulin pumps, have had unfortunate track records in terms of interactions with MRI. And if your screening protocol is empty your pockets and I'm just going to check you out, doctor, because you walk in, you're a doctor, and I'm not going to go through the full screening process. Maybe I recognize stethoscope around your neck, or hemostats or laryngoscope in your pocket, jacket pocket, but you may not recognize that there is a little patch on their back or their abdomen that is a drug delivery system that may interact badly with the MRI. So simply assuming the process of emptying your pockets is sufficient to conduct the screening is not correct. And simply patting somebody around their waist may or may not do the job either. Here is a different insulin pump, and you can actually see the pump device clipped to this person's boot. And you can see the tube that goes up to the little tiny catheter that is probably embedded at the abdomen or around the waist. So the device itself doesn't even need to be at the location where the drug is being introduced to the patient. So we need to make sure we screen all of these patients. We need to not rely on old patterns or rules of thumb for that screening process. We need to make sure that even the physicians, allied clinical staff that come in, that they are effectively screened for things like insulin pumps. And here's just a newspaper clipping from an article a few years ago about a woman who was almost killed because of a negative interaction between an MRI and her on-planted insulin pump. So this is an example for which we have a track record of adverse events. So please, please, please make sure this is something you pay attention to. So for the insulin pump, the static magnetic field, it can potentially interact with the function of the device, our fourth item here. But mostly the body of those devices are largely plastic and circuitry and a little mechanics for the pump. The battery may be ferromagnetic. So there is the potential for magnetic field interaction, but it's not something that is likely to go flying across the room with a substantial amount of force behind it. Time varying gradients may negatively impact the operation of the device, again, device function, but not going to introduce specific potential hazards directly to the patient. It would be an indirect concern related to device function. And the RF magnetic field, probably not a major concern based on the size and materiality of these devices. But all of those things exempted, device function is a major concern for insulin pumps. Think also about the recent news story, the weighted vest with the MR technologist radiographer in Sweden. We need to make sure that the clinical staff, including MR staff, that we conduct effective screening for everybody. So to summarize, and before we get to our questions from the Q&A period, screening for patients should be embedded in the referral path whenever possible. If you have any control over your referring physicians, engage them in the process. Don't overburden them, but be tactical in terms of what questions you want answered by your referring physicians, by your schedulers. Identify the workflows for the different types of patients, your staff, visitors, and develop appropriate screening processes for each. For example, if you have a back door into your MR area, you may want to have ferromagnetic detection screeners and belonging storage at that back door side entrance. Have a formal risk assessment structure to aid in your decision making. Make sure that implant risk assessments and risk mitigation steps are informed by a formal structure that reduces variability between technologist radiographers and radiologists and allows for more consistent patient care throughout. And with that, I would like to thank you on behalf of Metrosense, on behalf of Gilk Radiology Consultants. Thank you so much for joining us. And Colin, I guess we'll use the time that we have remaining for audience questions.
Many thanks, Toby. That's really highlighted the importance of careful planning and process development. As expected, we've had many questions over the past 45 minutes, so let's see now how many we can answer. And the first one we're looking to take is, I've just lost the questions. Here we go. In some countries, money is not an issue rather than patient safety. What is your opinion, Toby?
Well, I would hope that we would never find ourselves in a situation where we were putting those two things at odds. And in fact, one of the things that I hope comes from a process like we've just described is a process in which the revenue or the throughput interests are really aligned with patient safety. So I would hope we won't pit revenue or against patient safety. And in fact, I think if you design your processes and systems smartly, they're mutually reinforcing.
Thank you. Next one. Will a ferromagnetic detection system at a doorway find hairpins and implants like you describe?
It's important to draw a distinction between ferromagnetic detection for projectile safety versus ferromagnetic detection for small object or implant screening. The papers that have been published to date that identify the effectiveness of implant device screening with ferromagnetic detectors all use the screening system, which happens earlier in the process than the magnet room entry. So there isn't a one-size-fits-all application or product from ferromagnetic detection. So identify what it is that your objectives, identify those, and work with a vendor supplier to help you find the right products and the right placement in your workflow to achieve the results you're after.
Many thanks. Moving on now to some of the case studies that you cited. Regarding the broken pacer lead, would you still go ahead with a body transmit coil without hesitation?
Oh, okay. So that's a wonderful question, and it kind of opens the door to the bigger issue, which is the structured risk assessments, the three-bucket analysis method. As you change parameters, whether it's what you're using for RF transmit or the position of the patient within the bore, or even the field strength that you're imaging the patient at, as you change those parameters, they should change the calculus. They should change whether you find the revised scenario equally acceptable. To answer that specific question, again, if it's me, and that we were saying that study was for a knee, if I remember correctly, if it's me, because I am very tall, if we were using the transmit-receive, the body coil for transmit, I still would be comfortable with myself as the subject. You get somebody who is 5 foot tall, then, or a pediatric patient, and all of a sudden I become a lot less confident in that answer, because now we're moving that retained pacer lead closer and closer to both gradient, maximum time varying gradient amplitudes, and to the RF transmit volume. So each of these things in a structured risk assessment should be weighted as a part of the overall answer. I hope that helps.
Thanks, Debbie. Moving on now to another of your examples. Regarding the small foreign body, I think this is the BB they're talking about, the ball bearing, would you still have no hesitation if it was located near the optic nerve, or would you surgically remove it first?
Another great question, and another point that kind of touches on how, when we begin changing parameters, we begin changing the risk calculation. So firstly, for the examples that we gave, we were moving through extraordinarily quickly, and so no one of them really got the attention that they might warrant in terms of sort of a full analysis of the risk assessment process. So when I was seeming cavalier about scanning patients with BBs, ball bearing inside the body, please don't misunderstand that as sort of, I'm not concerned under any circumstances, because the person who asked the question identifies something where, well, wait a second, in a different situation, the results of the risk assessment may be very different. If the BB is very close to a sensitive structure, a critical vessel, critical nerve, now all of a sudden the weight of the potential harm that might arise from that study, the potential harm goes up, because we're more likely, or just from a proximity standpoint, there's a greater potential for injuring an important structure. With respect to the BB, if it is spherical, if we have two different views, then I am less concerned about the potential for slicing, cutting action. I would still consider, potentially significant the risk of translational force acting on a structure such as the optic nerve. So that's not without risk, and I am not here to suggest to you that we take the radiologist out of this risk assessment structure, because this ultimately becomes a clinical risk-benefit question. We have to weigh the potential value of the study against the potential risks of proceeding with it. And that ultimate calculation or determination belongs to the radiologist to perform. So I love the question. I think maybe we need to do something more on risk assessment and sort of structured risk assessment process. But thank you.
Thanks, Toby. And I think we just got time now for one last question. How do we keep updated with the latest devices that are used by patients in the market? For example, nano-designed pain medication patches, insulin delivery, and sugar monitoring patches, etc.
That's a challenge, because there are new things coming out all the time. For radiologists and radiographers, I would really strongly encourage you to get involved in some of the MRI communities. If you're on Facebook, a commercial message for a group that I administer, there's an MRI safety group on Facebook, and things like these questions, people who come across new implants, devices, or objects, share information about that frequently in that forum. So whether it's the Facebook forum or something else, I would very strongly encourage MR radiographers, MR radiologists to be involved in these kinds of discussions with peers and through professional communities.
Many thanks, Toby. Well, I'm afraid that we've reached the end of our time now, and we do need to bring the webinar to a close. As ever, we've had many more questions than we've had time to answer now, but I'm pleased to tell you that within the next few days, Toby will be with us again to record a podcast as part of Metrosense new MRI Safety Talks podcast series. And that podcast will be focused around the main themes that we're unable to cover from the questions you've asked today. So if we didn't get to yours now, please make sure that you have a listen. The MRI Safety Talks podcast series is available from the Resource Center on the Metrosense website. You've got a link on your screen at the moment, as well as on Buzzsprout, Apple Podcasts, and Spotify, all the usual places. So now just a couple of final reminders from me. Firstly, for those of you who are looking to download your continuing education certification, you now need to click on the yellow certification button that will be available for the next 5 minutes for you. That's down at the base of your screen. Alternatively, look out for the email that you'll receive in the next few hours, which will provide you with a download link. Secondly, for those of your colleagues who are unable to attend our live session today, do encourage them to join the on-demand webinar at any time that's convenient to them. And finally, we do have a full program of interesting webinars planned over the next few months. So please do look out for the invitations popping into your inbox. So it just leaves me to say thank you once again to our speaker, Tobias Gilk, and especially for this webinar, because as you probably worked out, Toby lives in the US, and this is a very early start for him. So many thanks to Toby for that. And of course to all of you online for joining us today. So until next time, thank you, and as they say in these days, stay well.